Are we sending live? I guess so. Okay. Good morning and welcome to this session, Survivor Session 2, Challenges, Assessments and Treatments for Survivors and Families. My name is Hans Friberg. I'm a professor of intensive care medicine at Lund University. And today we have 4 great speakers. I will let the moderators present each one of the speakers. And I would like to start with presenting the 3 moderators. That is Gisela Lilja from Lund University, Marco Mion and Thomas Keeble from Essex Cardiothoracic Center in the UK. So this will be hopefully a very interactive session, and we will use the format that each one of the speakers will present their 5-minute summaries. You will find their full lectures on the web. So welcome everyone. I look forward to this immensely myself. And by this introduction, I will hand over the word to the moderators. And I will start with you, Gisela.
Thank you very much, Hans. And I'm very pleased to start to introduce the first speaker in this session, Donna Malley, that as me is an occupational therapist. She worked at the Oliver Sangwill Center for Neuropsychological Rehabilitation in UK. And Donna is, among other things, one of the authors of the book Brain Injury Rehabilitation Workbook. That is an extremely useful book with a lot of practical tips for us that work in cognitive rehab, where Donna have authored a chapter on fatigue. That is also the topic of our presentation today. So very welcome, Donna, and look forward to your presentation.
Thank you. I'm really pleased to be asked to speak today on a topic that's really close to my heart. And this is about understanding and managing fatigue following a sudden cardiac arrest. And this is important because Paul Swindle of the Sudden Cardiac Arrest UK organisation conducted a survey earlier this year, and of the 230 respondents to that survey, 93% of those respondents reported experiencing fatigue at some point following their sudden cardiac arrest. So it's extremely important that we address this because it affects rehabilitation outcomes, it affects quality of life in individuals and their carers, and it also has an impact on rates of return to work. So it has a wider societal impact as well. Next slide, please. So here at the Oliver Sangwill Centre, a number of us drew together our various understandings of fatigue and drew on the literature that is available. There's a growing body of evidence to suggest how we might assess and how we might manage fatigue, but actually it's still pretty limited. And one of the reasons for that is because there are multiple factors that actually contribute to a person becoming more vulnerable to fatigue after a sudden cardiac arrest. It might be due to primary changes in the way that the brain communicates with itself, and that communication can become disrupted and more effortful. It may be that the result of changes within the brain and changes to thinking skills. Actually, it means that thinking takes more effort. It may be that there are mood or physical changes. It could be due to changes to a person's lifestyle. So there are many different reasons why somebody might be more vulnerable to fatigue. And so step one is that we have to identify what's relevant for that particular individual. So when a person then tries to actually engage in their desired activities, certain activities might act as triggers for the fatigue, by which I mean that they really draw down on their available energy and resources. And what we need to do is to try to identify particular triggers for that individual person. When a person experiences fatigue, they often only experience it at a stage when their resources are almost completely depleted. And what we want to do is to try to support a person to raise their awareness more of the early warning signs of fatigue. But then we're all human beings and we might respond in different ways to information. And sometimes we might respond and use old ways of coping, just trying to push through it and crack on, or a so-called boom and bust approach. But actually that doesn't necessarily lessen our vulnerability to fatigue in the long run. And there are a whole range of different coping strategies that we can support an individual to develop that might help them make best use of their resources. Next slide, please. So really, in terms of managing fatigue, it needs a multidisciplinary approach, and the person who's experiencing fatigue is absolutely at the heart of that approach. So we need to have a shared understanding with that individual. And here's a quote from someone who said, "It feels like a monster has taken over your life," and just try to put ourselves in their shoes. We need to support that individual to learn their personal triggers and indicators for fatigue in order to be able to support them to develop a range of tools to maximize their available resources. So it's very much a collaborative approach. Next slide, please. So management of persistent fatigue is really complicated. It's a bit like being a detective. It's a really common experience. I want to impress, it is not laziness. You are not alone. It is really important symptom to address. But it takes a whole range of different types of assessment to work out what's relevant for that person. It's an individual experience. So some of the measurement scales are not really fit for purpose. They give us an indication, but actually what we need to do is listen to that individual experience. Support people to grade their activities and share their understanding with others. It's really important to know that you're not alone. Thank you. Final slide. Thank you.
Thank you very much, Donna, for that excellent overview of the fatigue problem. That is a really complex problem, of course. I check if there is any questions from the audience, but I would like to start with one question myself. What the time of the patients in the patient's recovery phase do you meet the patients at the Oliver Sangwill Center for Neuropsychological Rehabilitation? And do you think that it's the most appropriate time point in their recovery you meet them? Or when do you think the patients need support for their fatigue?
So at the Oliver Sangwill Centre, we tend to see people who have had some kind of acquired brain injury, and it's usually around about sort of 9 months and up to many years following their injury. I think in terms of managing fatigue, clinicians need to be involved as soon as that fatigue is becoming a symptom that impacts on that person's meaningful occupation. That might be very soon after. Many people find that they don't necessarily recognize it as a symptom associated with their cardiac arrest. And so is it something to actually present to a medical professional with? And it's not until people try to get back into their desired activities again and realize that perhaps they can't, that perhaps they think it's something where we need to seek help. But we can also help people many years following their injury who maybe have tried to go down various routes and manage it themselves, but perhaps not been successful in doing so.
Thank you. I agree. And I think it's also important to be able to support prior to having too much problems and give a good plan for how to return to activities like work. So there is a first question from the audience. Where do you get that assessment from, though, still trying 6 years on?
I guess it depends where you live in Europe. I can only speak for the UK because that's been my experience. So we're part of the National Health Service. And so we would encourage people who are experiencing fatigue or any difficulties managing day-to-day tasks to speak to their GP and ask for a referral. It might be to a consultant in rehabilitation medicine. It might be to a psychologist if somebody is experiencing primarily mood-related symptoms, or an occupational therapist could be a good place to start, because then we can actually help support that person and the GP make referrals to relevant health professionals that could be helpful along the way.
Thank you. So,
make a comment, Gisela, just with regards to fatigue and medicines, because a lot of the patients that we see often think, probably wrongly, that the fatigue they are feeling following their cardiac arrest is maybe related to their new medicines, which they may never have been on before. So beta blockers particularly get blamed for these certain things. I just wanted to sort of put out there that I think sometimes the medicines might get a bit of a bad name when actually this is actually an underlying problem related to the cardiac arrest, the brain injury, and it's seen in many, many major illnesses, be that stroke, be that post-sepsis, be that post-ICU, and certainly be that post out-of-hospital cardiac arrest. So it was really just for everyone out there to say, you know, the tablets can be the cause of fatigue, but at the same time, these tablets often are very good for our patients, and that actually it's the condition rather than the medicines. And it's just an important understanding for both our patients and for our healthcare professionals that look after cardiac arrest patients long term.
I would absolutely endorse that, Thomas, because, you know, there are many different factors that contribute fatigue. One size does not fit all. There's never kind of one explanation. And so often it does take a little bit of unpicking, and therefore a combination of different management strategies to help. And never stop medication because you think that's the cause without speaking to your doctor first. That's really important.
And I think that just highlights, with all due respect, the need for a completely multidisciplinary team. You know, multidisciplinary teams are sometimes sort of just off the cuff, a terminology that we use as best possible care. But, you know, as I say, our clinic at the moment does not have an occupational therapist sitting within it. And I think we clearly need one. You know, we're putting it together, but we don't have one currently. We have what we have available to us. And I think we must aspire to have an occupational therapist clearly within the team that we have. And currently we don't.
this is, again, the combination of cardiac and neuro rehabilitation is optimal, I think. We have a lot of experience from both sides that could be combined to something really good. Yeah. So I don't think there is any more questions by now. Do you have any questions, Marco?
No, just a comment there. Really, fatigue seems to be at the very top of the list of issues that people experience after a sudden cardiac arrest, and something that they would like us to look at a bit more whenever we meet them, when they come back for a review. So really, really good to have started this session with this topic. So thank you very much, Donna, and hopefully we'll, in the future, and other teams as well, look at this a lot more, because it can be very limiting in people's lives. The other issue that people often report after a cardiac arrest is issues with cognition and memory in particular. So we do know from research that around half of the survivors do experience some degree of memory problems. And so I'm very glad to be able to introduce Professor Barbara Wilson, who is a world-renowned expert on memory and cognitive rehabilitation. I believe she's now semi-retired, but she's been working in this field for well over 4 decades, I believe. So she's probably the best one to talk about this. So over to you, Barbara.
Okay, thank you very much, Marco. Can everyone hear me? If we go on to the next slide, please. Right, so there are 3 main strands to helping memory impaired people. One is helping them learn more efficiently, because one real handicapping problem if you've got a memory difficulty is learning new information. So there are various strategies we can use to help people learn more efficiently. We can help people compensate through using external memory aids. And we all do this all of the time. We all use notes, things to do lists, so asking people to remind us. And there are special ones designed for people with memory problems. And the third way is to structure the environment so that they don't need much in the way of memory. Now, these aren't mutually exclusive. We can do all of these things, but I think for most memory impaired people that are going to come through to seek help after a cardiac arrest, it's probably the first 2 that are particularly useful. And if you listen to the talk, I give you examples of each of these: ways to help new learning, ways to help people compensate, and ways to structure the environment so you don't need so much in the way of memory. The other point I wanted to make is that memory rehabilitation is influenced by a number of theories, models, and frameworks. If we're just sticking to one approach, one model, one theory, one framework, I think that's going to lead to poor clinical practice. It's evidence-based, at least to some extent. There's lots of research into all these strategies I talk about in the actual talk. It's certainly patient-oriented. We're concerned with helping the patient, not building new models or doing a particular research project. We're starting with the patient and his or her family. We've shown from some of our work that we can save the health and social services money, and we can certainly improve quality of life. So they're the main things I wanted to say, or I do say in the talk. And then if we go on to the next slide, please. So the general conclusions then, rehabilitation makes clinical and economic sense. There's plenty of evidence for that. And if you hear people say there's no evidence of its effectiveness, they're wrong. There is evidence. And the next point on this slide, we need to draw on a number of different models and theories. And the next point, rehabilitation can help people compensate for, bypass, or reduce their everyday problems, and thus survive more efficiently in their own most appropriate environment. It's usually going home or helping them while they are at home, but some of our ex-clients may need to go to long-term care or a halfway house, and wherever they're going, we've got to get them to the best level. And the next point here, and it is possible to combine theory, scientific methodology, and clinical relevance. So all of the studies I've been involved with, we're tackling real life problems, not some theoretical or hypothetical situation. And then if we go on to the final slide, I've just put these possible questions up in case people wanted to discuss these. Consider some of the advice we can give to memory impaired people to improve their everyday functioning. If you're going to design a memory app on a phone or an iPad or a computer, what functions would you want that to have? And finally, what are some of the ways we can teach new information to memory impaired people? I think that's all I wanted to say, and I'm happy to take any questions. So thank you very much.
Thank you very much, Barbara. And I will definitely invite everyone to have a look at Barbara's presentation, because it's really interesting, with lots of information about what has been done historically and what we can do now to support memory, because obviously it's a rapidly evolving field, especially considering all the external supports we can have now with iPads and phones and computers, etc. But obviously it needs to be very tailored and specific to the memory difficulty that is being experienced. I'm just checking the questions now. That still at the moment doesn't seem to be any particular question from the audience. So I was just wondering, because most people after a cardiac arrest will experience some memory difficulties, but usually they are quite mild. And no, we all take, and it's really important message from your presentation, that it's really possible to improve memory difficulties. Sometimes people think, oh, that's what I've got to live with. But that's not necessarily the case, that there's different and evidence-based approaches that can help us to overcome difficulties. And there's, as you showed, at least 3 different strengths: simplifying the environment, to doing things differently, etc. And I wonder whether you have any particular kind of generic, although things should be quite specific, but just something that people can use. If it is the first time that they listen to people talking about memories and no one has asked them the this question, have you got memory difficulties, etc. So what can they take home? Is there any particular approach, or what's your recommendation for people that now are listening to us, maybe for the first time, that do have mild memory difficulties, that have been thinking, well, I've got to live with it? What do you say to them?
Yes, well, first of all, they have to understand what their particular problems are. I mean, it may be that they are particularly irritated by the fact they can't remember to take their medication on their own, or they can't remember things they've been told. So you need to identify what your problems are. Certainly avoid drugs and alcohol, because they do make memory worse. at least as far as possible. But if you should want to simplify any information. So people remember short words better than longer words. Even if they understand the longer words, it's easier to retain short things. Do one thing at a time. Just as an example, if you're going to, say, physiotherapy, it's no good the physio saying to you, I want you to do these 3 exercises, just one at a time. And if you're trying to learn something new, people's names, learn one thing at a time, not 10 at once or 6 at once. But I would also probably try and get hold of a memory manual. And my colleague, Narinder Kapoor, has done a recent memory manual that's in several languages. So I would have a look at one of those and see if you can be helped by some advice in there. I've done a couple myself too, but the most recent one is Narinder Kapoor's, and I know he's it's easy to get hold of that. So with any of the questions or anything from the talk, if you want to email me, I can give you the right information from that. So I think
just checking the
Yeah, I can continue with a question from the audience here. I just want to comment on Barbara's comment there with avoiding alcohol and etc. Also be aware of the fatigue. Even if the memory is quite okay, when you become fatigued, the memory will decrease. So fatigue management is very important here too. I have a very important question here from one in the audience, is that getting access to professional help is not always easy. Please, Barbara, can you help? What can we do for ourselves, and where could these patients that have these problems get help?
Well, I think like Donna, it depends on where you live. In some cases, it's relatively easy. I always think if you're going to have a problem, have it in the Netherlands, because easy access to funding and government money and professional help. In the UK, we sometimes say a postcode lottery. If you live in certain places, you can get access to help. But if you can't, you need to pester people. You need to pester your member of parliament. You need to go to the local press. You need to make a fuss, and then often you can get help after that. I mean, I'm a neuropsychologist. It doesn't have to be a neuropsychologist, OTs, speech and language therapists. We're all involved in helping people with memory problems. And often there are community services that you might be able to access. I mean, it's difficult to give one answer because it does depend a lot on where you live. You know, there are some countries it's just never going to happen. I know in India, for example, there are 1 billion people and 12 qualified neuropsychologists. So there you have to work through the families. And the psychologists there advise the families. So that might be another way of getting access to this help. But the person who asked that question, I suggest they email me, tell me where they live, and I might be able to put them in touch with somebody in their own country that can offer some of this help.
That's a really important point. Yes, we sometimes must be able to work in a creative way and obviously involve families and as much as possible to give out strategies and ways to tackle the problem that are helpful for the person in question rather than general strategies. Yes, and I've got another question from the audience about tips for finding right words, which I think is it's probably a presentation in its own because it's a very common problem, just having a word on the tip of your tongue and not being able to retrieve it. Don't know if you want to mention something quickly about this.
You're right. Word finding difficulties are very common after any kind of injury to the brain. I think you probably should be talking to a speech and language therapist there too. That's what I'd do anyway, if it was one of my relatives.
Okay. And another question which I think might be of interest to many is time a healer regarding memory?
Well, it's an interesting question because certainly at the beginning, people do recover. But after a cardiac arrest, the memory problems are caused by shortage of oxygen to the brain. And that affects the hippocampal areas in the temporal lobes there. And that's very sensitive to any kind of shortage of oxygen, as you know, Marco. So, but there does tend to be recovery for the first. I don't like to put a time limit on it because, you know, people can, but eventually somebody's going to plateau out. But I've recently done a paper of showing somebody that's still recovering after 22 years. It's very much slower now, but she's still recovering. Now, she didn't have a cardiac arrest. She had a kind of autoimmune encephalitis. But people can go on recovering for quite a long time. But if you've got somebody with severe memory problems, you're not going to restore their memory functioning. Somebody's very amnesic because of a severe shortage of oxygen to the hippocampal areas. If they're very amnesic, they're not going to recover. You have to go down the compensatory route and helping them learn. So the answer to that question is yes, there is some recovery at the beginning, but if it's not a question of trying harder or putting an effort into it. If those areas in your brain are really damaged, you're not going to restore your memory functioning. You have to get round the problem.
Everyday memory can still improve by strategies.
Yeah.
Yes, you compensate. You compensate for your memory difficulties. And a long-term study I've done, people do learn to compensate better even after they've left rehab, when we're teaching them all these things. Once they really know in real life, I have to do this, then they do help themselves to compensate. And that, in that sense, then recovery can go on for a long, long time.
Hans, you had a question. You're muted, Hans.
Thank you very much, Barbara. Excellent talk. I have a question, but you have, in a way, already answered it. The question was whether this is generic advice, or whether these problems and these methods for compensating are specific for post-cardiac arrest patients. But you have, in a way, already answered it. These are more general, I understand.
Yes, I think there's two parts to this. There's some general advice that you can give to anybody with memory problems, but then the particular problems of an individual, you need to tailor the treatment to him or to her. So I think both of those approaches are correct.
Thank you.
You're welcome.
Thank you very much. And definitely our experience, especially in the early stages post-cardiac arrest, is that memory does get better in the initial, as you said, it's difficult to put a time limit, and perhaps we shouldn't, but it gets better in the first few months, for some people many months, potentially many years, but then it's a matter of adapting sometimes and do things slightly differently, frustrating as it might be. Now, I would like to move on now, and just going through the hypothetical list of things that people experience after a cardiac arrest. So we mentioned fatigue, we mentioned memory and cognitive problems, and very high on the agenda, there's also issues with regard to the psychological and cognitive, but mostly psychological consequences of a cardiac arrest, which are really, really significant. So I'd like to introduce my colleague, Dr. Rosalind Case, who is a senior research fellow and a senior clinical psychologist working in Victoria, Australia. Over to you, Rose.
Thank you, Marco. Hopefully I've turned my microphone on now. Hi everyone, my name's Rosalind Case, and I'm really pleased to be able to listen to these talks, first of all, and hear from these people on this panel, but yeah, also to say a little bit tonight about the assessment and treatment of cognitive, but primarily psychological problems. And by psychological, what we're sort of referring more to are the emotional, behavioural, what might be referred to as psychiatric issues that can follow and go alongside brain injury, but also for people who don't necessarily experience any hypoxic brain injury after cardiac arrest, they might still go on to experience lots of different emotional challenges along the way as they adjust. Next slide, please. So in my talk, I tried to focus really, I guess, on highlighting the fact that there's just no typical recovery after cardiac arrest. And if you meet one cardiac arrest survivor who's had a really good recovery, it might be easy to assume that that's what it looks like for everybody. But it can be really different for each individual. And sometimes the changes that people experience are quite subtle. And the sorts of psychological issues that people are at risk of would include mood problems. So in terms of what we would call depression, but the symptoms of depression, including things like increased tearfulness. Fatigue is actually a primary symptom of depression and often gets mixed up in this as well. Low motivation or apathy, which is also potentially a brain injury symptom in itself. There can also be sort of behavioural issues. People talk about increased irritability or reduced what we call frustration tolerance. The one I hear the most is that people find that the kids just get on their nerves a lot easier and they find themselves shouting and then feeling bad about themselves and not really realising that this is actually a really normal experience after cardiac arrest. I think in the research field, what I've observed is that there's a little bit of a hyper focus on this idea of PROMs or patient-reported outcome measures and screening tools. But I think what we see is that the screening tools we have, psychological screening tools, don't do a complete job at identifying and really describing or capturing the experience of survivors or their families. We see that, quite a number of studies have shown that individuals have normal anxiety and depression levels, or they're not significantly different from the general population. But when you talk to people, they tell you quite a different story about the emotional challenges they're having, which leads me to wonder, are the constructs or the kind of these ideas of depression and anxiety, is that what we're really getting at? Certainly for some people. But there are so many unique challenges. And screening tools are really useful. I would really like to see them being used, at an inpatient level in ICU, which is where I personally use them, and then from there onwards. But if somebody shows up on a tool like the hospital anxiety and depression scale as having an elevated score, that still doesn't tell us enough. So I would like to, recommend to any clinicians listening and to survivors or family members out there, if you are concerned about a person's emotional well-being in any way, please refer them for further psychological assessment so that matter can be clarified. You don't have to have the answer to make the referral. And comprehensive psychological assessment is another thing, again, beyond screening. Next slide, please. So then when it comes to talking about treatments, I'm really hesitant to say, well, here's how we treat this or that, because psychological treatment delivered by a psychologist is often quite an involved process, and it should follow from a really thorough, comprehensive assessment. And I think, as previous speakers have highlighted, a tailored conceptualization of what is happening for this person, why them, why now in this context, and in particular, what is keeping it going, what are the perpetuating factors or the dynamic factors that we can try to change, because that's where we should be targeting our interventions. And then it's the job of a psychologist to then refer to the evidence and the scientific literature to work out what combination of strategies can work. In saying that, we do know that if you have low mood, it's good to try to behaviorally activate, get out and do stuff, socialize more, essentially do the opposite of what depression is telling you. If you have anxiety, most treatments are primarily focused around exposure to fed stimuli. So doing the opposite of whatever the condition tells you to do. But really getting proper support and assessment and intervention is critical at that point. Next slide, please. So I just popped up a few ideas for questions for both the audience and survivors in the audience, but also clinicians or researchers or anyone else interested. Firstly, how do we know when a referral for psychological assessment, full and comprehensive psychological assessment, whether that's by a clinical psychologist, a health psychologist, or a neuropsychologist, is indicated? And I think that's a question for clinicians, but it's also one for survivors. Like, how do we know as people when we need this? And I would put it out to the survivors in the audience and ask the question, if there is a point at which you've thought for yourself, I need more help, and you have perhaps sought or had access to that, what has that point been for some people? At what point do they think that should be occurring? And thinking about how this sits within a care system, I think it breaks my heart when I hear survivors asking these excellent questions about, how do I get access to this? This is just not good enough. And we are not doing a good enough job of creating systems that follow survivors along their recovery journey. It's not enough for the doctors to high-five each other as the person goes out the door on their very long survivorship journey. So we need to really be working a lot harder to do this. And I, again, echo everything Barbara says, just the squeaky wheel gets the oil, but it's hard to be squeaky when you're tired. So please don't hesitate to send an email to any of us and ask. And even if we're not in your location, we would be happy to try to link you in with people who are. And finally, I realize I'm probably going on, but I also think the other thing we need to think about in that context is that there might be people from all around the world, hopefully today listening, and that there are going to be specific cultural factors around the acceptability of certain types of services, and geographical factors that need to be considered. So the people in each of those locations really need to be supported and collaborated with to develop that. I think that's all.
Thank you very much, Rosalind. And I mean, as a psychologist myself, I couldn't agree more. There's quite a lot of work to be done. It's true. I mean, probably screening for psychological difficulties after cardiac arrest needs in itself a lot of work, but then it's also about what do we do then, because there seems to be internationally a lack of dedicated care pathways, which seems to be really needed. And we're not just talking about the survivor, we're talking about other the bystanders or family members that have responded, etc. And looking at the questions that are coming up, there's obviously people that say, yes, I know I have a problem, it has been identified, but I don't seem to be able to get access to the right type of support. And people always seems to fall in that in between sort of mild mood difficulties that are proportionated to the experience, to the severe mood difficulties that then get looked at, but then they're somewhere in the middle. And that seems to be very frustrating, because there seems to be very frequent and common issues for many survivors. Any ideas or any thoughts on that?
Yeah, I agree. I think I don't know what the system is. I'm guessing that the NHS system's a bit more like what I'm used to back in New Zealand when I worked there, which was that everything was free, but it was harder to get access to things, maybe because you had to kind of meet that higher threshold. Here in Australia, we have this Medicare system, which enables people to get 20 rebated and potentially free sessions with a psychologist per year via their GP. And in Australia, if there's survivors there, currently provide bulk bills online sessions to anybody who's had a cardiac arrest. If they want to email me and get a referral through the GP, I do that for free. But I think it really is about, again, just trying to tap who's in your country and ask us today, and if we can try to start building this up. You know, I think it has to start from a grassroots level, because it sounds like it's not going to happen from top down.
Yeah, there's a comment from
essential. Yeah.
It's a comment from the audience saying that no, this needs really to get into the guidelines to be able that people can access in the future. So we really need to lobby people who are decision makers, so to make sure that this gets there, so that people have access.
And it would be nice to see psychologists participating in more of those conversations as well.
And you're
European guidelines that screening should be done. Considering screening, Rosalind, you said that screening already for emotional problems in the ICU. My first
no.
Isn't that a bit early? When in time do you think?
It depends, I guess, on how you view it. Like if we're tracking people long term, I actually, again, I use quite brief screening things, and it depends on the person. But yeah, we're trying to track things over time. So often in the ICU, you're kind of tracking around delirium.
But not the HADS.
Well, no, I mean, I wouldn't use a HADS in clinical practice very often anyway, because it's a crude measure to use in clinical practice.
Yeah.
Like it might, you know, have a purpose there. But no, in the ICU, I'm using a lot of the NIH toolbox.
Also, isn't it normal to have like emotional distress in the beginning? Because for me, working with brain injury, it's more, I got more concerned when they are not feeling anything in the beginning, if you understand what I mean. So where is the threshold for when to start be a bit stressed about this not going back?
It might be my context, because I work in the heart transplant part of the hospital as well. So we're screening from before, pre-operatively. A lot of those patients cross over with cardiac arrest as well. I'm of the opinion that if we can, it's good to be capturing data where indicated for the purposes of kind of monitoring and tracking. And so, yeah, if somebody's in a coma, obviously I'm not going to be screening them, but if we've got people waking up and they are coherent and sounding depressed, then we might as well be measuring that. If we can do it in 2 minutes on an iPad and anyone can do it, then I don't see why we wouldn't capture that information.
Yeah, this is a really good point, and seems to address to some extent one of the questions, which is when is a referral indicated? Possibly at the point when you're overcoming physical issues such as fatigue and realize you're still struggling nevertheless. And that's a really good question, isn't it? Because what answers we get also depends at what point we ask the question. And many people
look, the referrals that I've had from cardiac arrest have typically been around 4 weeks to 6 months post-arrest. Sometimes it's actually the person's family member contacting me because they're so concerned about the depression, post-discharge depression. But sometimes it's people struggling with their adjustment after 3 or 4 months, and that's when they need help. I've got preliminary data here to show that anxiety and depression sort of levels look more resolved around 12 months, but when you look at 3 to 6 month mark, that's when most people seem to be really struggling, and subjectively that's what people have told me in qualitative research too. So it varies for everyone. I think that's why we need good monitoring and follow-up, and you need a care team that knows you and knows your family and is linked in, and providing that monitoring and oversight and support for referral. Because when you're unwell, you often don't know, or these things are so insidious, and you're too vulnerable to make those decisions for yourself and try to access that.
Thank you very, very much. It's a really interesting conversation. I think we have to move on, though, to the next speaker.
Thank you.
No, thank you, Ros. So our last speaker is Professor Karen Smith. She's also from Melbourne. She's the director of the Centre for Research and Evaluation in Ambulance Victoria, Australia. She's a chief investigator for OSROC, and she's the founding member of the International Task Force for Cardiac Arrest Recovery. And Karen's going to talk about an incredibly important subject, which is that of returning to work. Many of our patients are young, of working age, and obviously a huge important factor is their ability to get back to work and get back to normal functioning. So she's going to talk about that now. So thank you.
Am I on? I can't see myself. It's disconcerting. So yeah, thanks everyone. And it's so great that there's a survivorship stream now in the conference. It's really heartening to see, and it's really great to be part of this esteemed panel of speakers. And I think listening to what everyone's been saying, to me, it just really highlights that need for all of us in this space to be advocating for that evidence-based rehabilitation pathway that really doesn't exist at the moment for cardiac arrest survivors and their families. And, you know, the issues of fatigue and psychological distress and memory, you know, could be addressed early in those rehabilitation pathways, at least to the point where we could be highlighting to survivors to be looking out for these signs and to be intervening early, and so that they realise that these things are perfectly normal within the space, and yeah, and that there's things that they can do and people that they can see to sort of help that. Anyway, so my part of it is talking about return to work, which, as Thomas said, is really important to a lot of survivors. You know, in the cohorts that we've seen in Victoria, a really significant proportion of cardiac arrest survivors were working prior to their arrest. And we know that work plays an incredibly important role in someone's life in terms of their identity, their physical and mental health, and how they see their purpose and also their position in society. So it's really fundamental to a lot of people's well-being and how they see themselves in society. So, and we know that return to work has, you know, following critical illness, has been associated with improved health status and recovery and improved quality of life. But there's that challenge to work out. We know that returning to work improves quality of life, but we also know that having a decent quality of life makes you more likely to return to work. So the interplay between those things is really complex and something that still needs a lot of research. And this particular topic in terms of cardiac arrest survivors and returning to work is actually something that hasn't had a lot of research done on it. So, but we know that being able to return to work is indicative of, to some degree, returning to your pre-arrest function, and is seen as a positive outcome, obviously, post-cardiac arrest. So next slide. Oh, actually, 2 slides. Thanks. And like I said, so to date, there's been very few studies on return to work in the cardiac arrest cohort, although Gisela has done a very nice one looking at a cohort of patients from the targeted temperature management trial. But from the studies that are out there, we see that the percentage of patients returning to work post their arrest are around the 62 to sort of 77%. In Victoria, we see about 73% of our patients who were working prior to their arrest back at work within 12 months of their cardiac arrest. But when we look at patients, we see that the barriers issues that we predominantly see either in stopping them from returning to work or are still there even once they've returned to work. And the big one that comes up, and we've seen this as a predominant theme in the talks that we're seeing in this session, is fatigue. And then the other one is cognitive impairment. So again, that would align with the memory issues, and even mild cognitive impairment can be an issue with returning to work. And then there's other simple ones like medical restrictions, such as people needed a license to drive, and then they have been not being able to get their license post-arrest and things like that. So, and one of the things that really comes up as a common theme in all the studies, and we certainly saw it in our study in Victoria, is that men are much more likely to return to work than women. And to some degree, this may be that men are the primary income earners, and so the impetus and sort of the push to return to work is higher. But even after adjusting for factors like quality of life and various factors, we still see that men are much more likely to return. And we've done studies in Victoria as well that show that women have poorer quality of life post their cardiac arrests than men. And again, this is after adjusting for numerous factors. And there's research to suggest as well that the resuscitation, in terms of how aggressive the resuscitation is and whether they're likely to go to a PCI hospital and things like that, is less likely with women. So that trajectory happens from the point of resuscitation. So this is something that really needs more exploration to sort of increase that or reduce that inequity that we see there. And like I said, the quality or the interplay between quality of life and return to work is not well understood. And we really need to look at how these issues can be addressed through evidence-based rehabilitation. And I know we've been talking with the task force with Thomas and Marcus and Roz in terms of what like a basic rehabilitation package would look like, that's standardised and evidence-based, that can be built on, so that survivors have access to this across the globe. And just to sort of finish up, obviously return to work is only one measure of sort of returning to pre-arrest pre-arrest health. So there's certainly people who don't work prior to their arrest or choose not to afterwards, and so we need to be looking at other factors that are indicative of returning to pre-arrest sort of quality of life, and that's things like participation in hobbies that were important, and things like that. But just to finish up, there's lots of work still to be done in this space, and it's a really important thing that we need to keep looking at. So hopefully people had a chance to look at my talk, and thanks for the opportunity to be on this panel. So it's a really important issue.
Fantastic. Thank you very much, Karen. Gisela and Marco, can I ask you if there are any questions coming from any of the audience with regards to the final topic?
Yeah, there's a comment which I think is a very powerful one. So what it says is, as a survivor, the routine of work was the most important factor for getting back to some sort of normality, which I think we've observed this quite often, isn't it?
Yeah, and I think that's one of the important things to sort of to address in rehabilitation, is to be asking, what are you working towards and what's really important. And I'm sure a lot of patients will say returning to work, and so then how do you address the fatigue and the memory and all of those things so that that's possible.
Here's a question from Marieke Blom. Great presentation, Karen. Do you know of interventions that have had positive impact on return to work? And I don't know if she mean cardiac arrest survivors specifically, or return to work after similar situations or events.
No, that's a great question, and I can't think of a study that's shown a particular intervention that's been associated with that, but maybe some of my colleagues on the panel might.
Yeah, I work with
an outcome measure.
Yeah, I at least work with rehab for stroke patients that are in working age, where we support work return, and I can see that we provide so much for these stroke patients compared to what we provide to the cardiac arrest survivors when the symptoms is the same. So I hope these care pathways that are available for other types of brain injury patients or patients having an event will open up for cardiac arrest survivors too. Because there are strategies to be used that is useful.
Yeah, absolutely. I'm not aware of any specific study about return to work after cardiac arrest. So this
not
is a
the intervention part.
No, not intervention. A completely untapped area. But
But Karin, in your study, the survivors in the qualitative part describe that they have adjusted and they use strategies. Do you know if they were provided rehab?
No, we did actually ask that, and I can't remember what percentage said they were. It's not as common in Australia as in other areas. Particularly cardiac arrest, like you said, stroke. We have an evidence-based rehabilitation program that most stroke survivors would go through, but it's not the same in cardiac arrest. So the things that really came out in our study were things like the employer offering flexible work arrangements, so reduced shifts or reduced hours and things like that, or job sharing. And that was a strong theme. So if the employer allowed some flexibility, they were much more likely to return back to work.
Karin, thank you for that fantastic overview of return to work. I'm going to return to Hans now, who's very kindly going to sum up, because we've got about a minute and a half or a minute now just to sum up the session. So thank you.
Thank you, Thomas, and thank you, everyone. Thanks to the speakers and to the moderators. This was a fantastic session. There is so much gathered knowledge, joint knowledge in this group, and I hope everyone has enjoyed it as I have. There is a lot of hope. There is some frustration. There is a huge potential, I would say. And there are some keywords that I have put down here. Collaboration, multinational collaboration, multidisciplinary approach. These are things we must focus on. And there are many general advice, but also tailored or individualized solutions to survivors and their families. In real life, this boils down to, in my life, in my environment, that primary care, the GPs and those structures must take more responsibility and have structures where they can help survivors and relatives. And all of us, all of you rather, will help us organize and such a structure. So huge potential, a lot of hope, and I thank you so much, and I thank the audience for listening, and see you again at the next conference, if not sooner. Thank you.